Any questions from the last stuff that we covered? So who would I not want to give metformin to? Or renal okay, so what does renal mean? I mean, you're all technically renal patients. Y'all have kidneys, right? I assume. What's more specific marker could they use? Yeah, so they have like maybe chronic kidney disease, kidney failure. Usually we use like a creatinine clearance cutoff, so if it's like less than like 30, certainly would not want to use it there. What's the risk for doing that? Lactic acidosis, right? Because again, you're not going to be able to clear it as well, and then it will accumulate. So more metformin means you can develop more of that lactic acid and then get that lactic acidosis. Very good. What's a common side effect from using insulin? So hypoglycemia is like the most worrisome one. Hopefully it's not too common, right? Hopefully you're not giving too much insulin to your patients. It's a common thing though. Weight gain's a big one, yep, certainly, for sure. How much glucose would I give to a patient, say they were hypoglycemic? I'm not gonna ask you like specific dosing on the test, but just as a general rule of thumb, how much glucose, how many grams of carbs would I give to a patient? You remember that rule of 15? So you give them 15 grams of carbs, wait 15 minutes, see how they're doing at that point, and they can repeat if you need be. What do I give them? Say they're unconscious, they fall out, and then I need to get them something to get their glucose up. I can do glucagon, right? How does that work? And where? Very good. So stimulate gluconeogenesis in the liver, and then what else could I give them? Dextrose, yeah, I can give them sugar, right? So I can just give them IV dextrose is usually the most common thing there. Very good. Anyway, so a funny thing happened on Sunday. I was taking my kids to SeaWorld, and so we were driving, and their mom wanted to stop off at McDonald's before we got there to pick up some snacks. And so the whole way my daughter's like, all right, we're gonna go see the animals. We're gonna go see the animals. We're gonna see the animals. And I'm like, yes, we're gonna go see the animals, yes. Very excited about stingrays, right, because you get to touch them and stuff. But we get to McDonald's, and my wife hops out to go get the food from inside, and my daughter's like, okay, let's get out of the car. And I'm like, no, we're not getting out of the car yet. We're at McDonald's. Mom's gonna get some food, and then we're gonna go see the animals. She's like, okay, so we're gonna go eat the animals. I don't think they do that, honey. I don't think you pay enough to get that kind of treatment. And I thought about which animals would I want to eat from SeaWorld. Not many of them, so that's good. Anywho, so getting into other anti-hyperglycemic agents here. So we talked about our sulfonylureas. They work by doing what? They stimulate direct release of insulin from the pancreas. Then we have our biguanides, which metformin is really the only one in that category. Then we have our thiazolidinediones, or TZDs for short. Two main ones in this category are pioglitazone and then rosiglitazone. That's Actos and Avandia. There was troglitazone, but that got taken off due to liver failure. So these also are going to be insulin sensitizers. They're going to make the insulin that you're already producing work that much better. And this is going to be working on this PPAR gamma transcription factor, and basically you're going to be able to transcribe and produce more insulin sensitive sort of proteins, right? So again, it makes your insulin work that much better. So if I wanted to use this in conjunction with other diabetic medications, which one do you think this would synergize well with that we've covered so far? They work well with metformin? Yeah, probably, because it would also help to sensitize even further, right, through two different mechanisms. Would it work well with, say, a sulfonylurea? Yeah, so you're kicking out more insulin from the pancreas, and then the insulin that you're sending out is also more effective. So that does make good sense. And you'll see, especially for these diabetic medications, that there's always going to be other newer combination drugs that are coming out. So metformin plus pioglitazone, metformin plus a sulfonylurea is pretty common. And again, why do we do those combo drugs? Besides the fact we get a new patent on that, we can make more money. The compliance aspect of it, right? Because again, these patients might also be on drugs for their hypertension, for their hyperlipidemia. Again, anything you can do to try to get the compliance better is going to be beneficial for these patients here. So again, what you're going to see is more peripheral glucose uptake into the peripheral cells, so more of that tissue insulin sensitivity there. And it may actually help to decrease a little bit of hepatic, I should say glucose production. I apologize for that. Your liver does not produce any insulin as far as I know, or that you know, I imagine. That should be hepatic glucose production. That's going to be diminished there. You may find things like protein binding issues there if you had like maybe another drug coming kicking off the protein, so you would want to be watchful for that. And watch your LFTs, because again, we saw troglitazone was just removed off the market for hepatotoxicity. So you would want to watch with these patients as well if they're on PO or rosiglitazone. It does take a little while to kick in, and that makes sense because it's working down at the nuclear level to transcribe new proteins, so it won't be as fast acting as something like a sulfonylurea might be. So a couple of weeks steady therapy should start to increase that sensitivity. So some patients you want to be careful of using the TZDs in, and this is mainly going to be cardiac patients you want to think about, especially if they have CHF, mainly because you can end up seeing this expanded blood volume, which can lead to fluid retention, edema, and can lead to worsened heart failure for those CHF patients. You do want to be watchful for that. Watchful in patients who have dyslipidemia, because you may see increases in your LDLs and triglycerides. HDLs might actually go up a little bit, which is, Yahtzee, right? That's totally fine, but watch LFT and LFTs as well. So typically you do it for the first couple of months for the first year, say every 2 months for the first year, and then if you did see the ALTs, for instance, go up, say 3 times upper limit of normal, then you'd want to go ahead and discontinue at that point. So again, if you get a little bump, that's usually no big deal, but then if you see, again, that 3 times normal, that's when you'd want to stop it. The other big thing they also noted as well is that there was concerns with increase in cardiovascular mortality, specifically with rosiglitazone. And actually, when they looked at individual trials, they actually found that they didn't have any specific effects in causing more death. And so, again, going back to our EpiBio lectures, you guys remember that? I try to repress those memories, but look, we have odds ratios, and so if you were to look at, say, for instance, this DREAM trial, it had an odds ratio of causing cardiovascular death or death from cardiovascular causes of 1.65. So that appears to be pretty worrisome, right? What would that mean?
60% of the time.
Well, they have 65% higher risk compared to people on, say, in the control group of developing death from cardiovascular. So it's not, overall, they have a 65% chance of mortality. That would be quite bad, right? But it's an increase in 65% above that. But again, what do you notice about the confidence intervals? Quite wide, right? And because we're doing odds and it encompasses 1, it means it's non-significant, right? And you can tell that by the p-value, so I didn't have to go through all that rigmarole. You could just see it right there, right? So they did seem a little bit worrisome, but actually when they ended up combining a bunch of trials, it either did achieve significance or it got pretty close to significant. So there was concern from that standpoint. So you start to see less rosiglitazone being used. Certainly pioglitazone is still used on occasion, but this kind of scared a lot of people, especially in patients with high-risk cardiovascular history, so they kind of backed away from that a little bit. But still good drugs overall, so you may still see it being used in more of those low-risk patients, but definitely not in CHF patients. Up next, we have our alpha-glucosidase inhibitors, and so this is actually going to be inhibiting an enzyme called alpha-glucosidase in the actual GI tract, and so basically it's going to be preventing glucose absorption by preventing breakdown of sugars into smaller, more easily absorbable molecules, basically. We have 2 in this category called acarbose and then miglatol. You'll see these are not going to be used too frequently. What do you think could be the side effects of having a bunch of extra glucose in the GI tract not being absorbed? Or like diarrhea. What happens to all that sugar? Maybe draw in water, right? So you could see like maybe a little bit of diarrhea because of that. Is there anything in the GI tract that maybe wants to eat that sugar? Bacteria. Oh, okay. So you eat sugar. What does that turn it into? Turn it into eventually CO2, right? So you can actually end up getting a lot of abdominal distension, cramps, flatulence, eructation, right? What is that? You're burping, right? So a lot of GI discomfort with this group of medications here. So as you might imagine, compliance is pretty poor, right? So a lot of people don't like to take these. The nice benefit, though, is the fact they actually don't get absorbed all that too well into the systemic circulation. So if you needed to have limited systemic exposure to medication, say for instance like with a pregnant patient, this might actually be okay. Do you think you'd want to give a drug that causes a lot of flatulence and abdominal distension to a pregnant patient, though, who is already having many GI issues to begin with? Probably not, right? So it's not necessarily going to be something you're going to use too frequently, but we still mention it because you might see it out there. We want to make sure they're actually going to be taking it with their meals, because again, that's when the glucose is going to be in the GI tract to actually be absorbed in those cases there. You may find small risk for liver dysfunction with things like miglatol, but for the most part, they have very low systemic absorption, very low chances for causing a lot of systemic issues in those cases there. And again, you can find this used in combination with our other oral agents we've already talked about. Sulfonylureas, biguanides, any of those would be fine combination. Insulin would be totally fine as well. So in terms of adverse effects, as I mentioned, diarrhea is a big one, abdominal pain, flatulence. So again, a lot of extra CO2 being produced by those bacteria there as they chew up the glucose. And then we'd actually not want to use this in patients who have a history of inflammatory bowel disease for sure. So like Crohn's, ulcerative colitis, so would not want to use these because again, that could worsen inflammation, worsen the disease for those patients there. Okay, so next we want to talk about a different hormone. This one here is going to be called incretin. And incretin is going to be something that is responsible for things like satiety, and there's going to be a couple different agents we're going to talk about here. But basically what you're going to find with patients who have diabetes is you actually end up finding that they're going to have impaired amounts of incretin they're actually producing, as we'll see in just a moment here. But basically incretin is something that gets secreted in response to oral glucose, right? So for instance here, if you're looking at, say, plasma glucose levels, and these are, say, two sets of patients, one getting oral glucose and then one getting IV glucose. And you notice here that if you were to give both of them, they get pretty similar profiles in terms of their actual glucose levels. On the other hand there, if you're actually looking at incretin effect, you can actually end up seeing that the patients who get the oral glucose have a much bigger spike there. So this is another one of those kind of central things where you're seeing the food, you're having it come in from the GI tract, it's going to be triggering that incretin to be released, as opposed to like IV dextrose, which wouldn't do that in most cases there. So we have a couple of different incretins that fall into this category, and so this includes one called glucagon-like peptide 1. It says glucagon-like peptide doesn't actually do what glucagon does. You're going to see it's going to be sort of antagonistic to that. But basically it gets released in response to increased blood glucose after a meal. And again, it has to be the oral intake there. And so basically you'll find that as GLP starts to go up in secretion here of the glucagon-like peptide, you'll find that you get increased glucose-dependent insulin release. It actually helps you to release more insulin. So that way you'll actually help to drop your blood sugar back down more quickly. And if you imagine if you had less GLP being released, what do you think that would do to your blood sugar? Raise it up even further, right? So again, that's why you're going to find issues with this with type 2 diabetic patients. You also find it will decrease gastric emptying and food intake because it actually will help to trigger the satiety centers in the brain so you feel fuller faster, okay? So what do you think would happen if I were to give someone exogenous incretins? What do you think would happen to, like, say, for instance, their weight? It actually decreased, right? Because they just don't feel hungry much. And so you're going to find this is a big use for some of our incretin mimetics, as we'll see here in just a moment. Anyway, you're also going to find some other cases here of different things like gene transcription and things like that it can affect as well. So pretty powerful set of hormones. GLP is quite powerful, but we're going to find it's going to be diminished in patients with type 2 diabetes. Of note, it's also metabolized by this enzyme called dipeptidyl peptidase, or DPP4. That's going to be important for another set of drugs we'll look at in just a moment. So anyway, as I mentioned, this is good because one, it helps to promote satiety and reduces that appetite. I'll tell you a story about a family member who actually got put on one of these medications, what kind of happened to them. But you'll find you're going to have less glucagon secretion. You're going to have less actual hepatic glucose output. So all of this is going to help get the blood sugar back under control, especially with mealtime ingestion of carbohydrates there. More insulin secretion, all that's really good. And again, less gastric emptying, so you feel fuller faster. You feel fuller faster because more of that food's kind of sitting there in the stomach. So what happens here, you're going to find that they will have these decreased levels of insulin as well as GLP-1 being secreted there. And I'll show you a graph of that in a second, I think. Also, if you recall from last time we met, you saw those type 2 diabetic patients. They also had excess glucagon being secreted. Normally, if you were to take in a meal as a non-diabetic patient, you would find that glucagon suppression would occur, right? Because insulin is going to be released, and so that should decrease glucagon levels. But type 2 diabetic patients still kept up those levels pretty high there. And so again, this is all trying to get things back into balance by doing this. And again, if you're fuller faster and eating less food, then that's just less carbohydrates to have to deal with as well. And again, looking at those levels we saw that previously where glucagon stays pretty high in those type 2 diabetic patients versus they have impaired insulin release as well, right? These are going to be more kind of later stage diabetic patients who've kind of started to wear out the pancreas. And then looking at that GLP-1, looking at how it's going to be impaired, remember the NGT is normal glucose tolerance. You have impaired glucose tolerance, and then type 2 diabetics, you see here, they have a pretty big diminished level of GLP-1 being released as compared to the patients with normal glucose, right? Or normal glucose tolerance. That's going to be something we may either try to maybe prevent the breakdown of. Maybe we can give something to block that enzyme DPP4 to try to get levels back up, or we can just replace it altogether by giving an exogenous form, and that's going to be our incretin mimetics, as we'll see in a moment. So, and we know what this is? It's a Gila monster. Why do I have a Gila monster on my slide? It's another animal source for a drug. We always like these, right? So if you look at it, things that come from We saw insulin comes from beef and pork potentially. We saw we can get heparin from Chinese hamster ovary cells that have been engineered to do that. We found calcitonin comes from what? Salmon sperm, right? So again, interesting sources for drugs. Here's another one here. So the first incretin mimetic we had is called Exenatide or Byetta, and this is actually isolated from the saliva of the Gila monster. Again, who was playing with the Gila monster, got some saliva, and figured out that this actually has a lot of homology with our GLP-1. So Gila monster spit is about halfway in terms of the amino acid sequence and similar to our GLP-1. I don't know why, but Earth is weird, right? But point being is we can actually use this in conjunction with things like metformin and other insulin sensitizers to help replace that GLP-1 that they're not producing anymore, and you'll get pretty similar activities here. Now again, this being a hormone we're injecting to the patient, being a protein, it has to be by parenteral routes, right? So this is not going to be an oral agent, this is going to be by injection. You'll find our DPP-4 inhibitors we'll talk about in a few moments, those can be oral agents. So if you had a patient who maybe you didn't want to, they were pretty needle phobic, they didn't want injections, this may not be a great set of drugs here. But you will definitely see weight loss because again, they're going to be intaking fewer calories because they're going to feel fuller faster, they just don't really feel hungry because that satiety center is being activated there. And again, this was the first one, so this one wasn't great from a compliance standpoint because you're injecting it twice daily. And again, imagine if your patients were on insulin as well, you're just adding that many more injections that they're going to have to give themselves. So not great. This one had a fairly short half-life as compared to some of the other ones we're going to see here. So, but looking at what happens if you were to look at, say, giving Exenatide, what happens with their insulin levels, you can see here they actually get a bigger boost, or this would be happen normally. Again, if you're looking here with patients with type 2 diabetes, you end up seeing that after giving Exenatide, they get a much better, almost very similar to what normal levels would look like in terms of insulin secretion there. So very nice to be able to replace that. If you had to imagine how expensive these agents are, pretty expensive or pretty cheap?
Expensive.
Pretty expensive, right? So different things you're going to find in terms of adverse effects here. You typically find that you don't get a ton of hypoglycemia with these agents by themselves, but certainly if you mix them with other things that secrete insulin, like your agglutinides or your sulfonylureas, that is a risk. So you do want to be cautious with that. But typically when used by itself or with just metformin, you don't see a ton of hypoglycemia. The other big benefit is going to be the weight loss, right? Actually, you end up finding pancreatitis in some cases as well. Again, kind of notable, interesting drug-related causes of pancreatitis. So anyways, I had an uncle who was very overweight for most of his life, had diabetes, dyslipidemia, total metabolic syndrome, right? And so he actually got put on one of these medications here, one of these GLP-1 agonists. And it was interesting because, you know, it's like one of those uncles you only see like at Christmas and at Thanksgiving. And so I probably hadn't seen him for like 6 months or something. And I came back and the guy was like a shadow of his former self. Like he'd lost so much weight. And I'm like, how'd you do it? He's like, I'm on this awesome drug. I just inject myself like 1 time a week and like I just don't feel hungry ever. So is there any negatives to that? Yes, like malnutrition can also happen. So a couple weeks later, he ended up in the hospital because he was having significant weight loss. He's vitamin deficient. I mean, it's just not great. So there's got to be a balance between these two, but it can be quite effective from a weight loss standpoint. So, but other things you're going to find, nausea, vomiting, you can typically see due to that decreased gastric emptying, kind of more food just sitting there on the stomach. You have some reflux, etc. And it may actually inhibit the absorption or delay the absorption of other oral medications, again, due to that decreased gastric emptying effect. So since then, we've had other agents, and again, this is kind of a big set of blockbuster drugs because they're so effective, and again, a lot of these patients are overweight, so it can help them get, hopefully, to a healthy weight loss goal in addition to getting their sugars under control. So since then, we've had ones like liraglutide, dulaglutide, and then albiglutide, and so these are nice as well because they have a much longer half-life, and so for instance, you only have to give this 1 time weekly in some cases there, so pretty nice from a compliance standpoint. But again, these are typically going to be quite expensive. They're still relatively new, so most of them are still going to be you know, brain only, etc. But of course, if maybe it helps you from having a heart attack or something, maybe it's going to be worth the money to the insurance companies in the long run. Who could say, right? But on the flip side of that, so instead of just giving exogenous GLP-1, what if we did the opposite and say, what if we prevent the breakdown of the little bit that they actually are releasing? So we can do that by inhibiting the enzyme dipeptidyl peptidase 4 or DPP-4. Do you think this will be more or less effective than the exogenous supplementation? Much less, as you're going to find. But the benefit here, these are going to be oral agents that we can administer. It doesn't have to be a sub-Q injection. So the big thing we're focusing on the fact they work on the breakdown of GLP-1, and by inhibiting that, you'll have increased levels. And so we have several that fit into this category here, including allogliptin, sitagliptin, saxagliptin, and then linagliptin. So you can always tell it's gliptin. It's going to be one of the DPP-4 inhibitors here. These also are not going to see the same amount of weight loss. It'll probably be pretty weight neutral to some little bit of weight loss, mainly because you're not really getting those big boosts in GLP-1 levels like you would with the exogenous supplementations there. But fewer side effects as well for the most part. There's a small risk for having some skin reactions like Stevens-Johnson's, but again, it's fairly rare. And just to give you an example of some of the synergistic effects you can get from combining these different medications together, if you imagine giving something like sitagliptin by itself, and again, look at this slide, these QD. Shame on them, right? We don't use that. But sitagliptin by itself, and then looking at metformin by itself, and these are pretty standard starter doses for these, you can end up seeing that by combining the two together, you do get more effect than just either one by itself. So you get some definitely good synergy there by doing that. So again, this is why the rationale for combining different medications together, why you see a lot of combo drugs out there on the market. So just to give you a slide just to remember the differences between supplying the patient with an exogenous form of GLP-1 versus inhibiting DPP-4. You see here that both of them will have pretty similar effects in terms of their effects on glucose and whatnot. Just the GLP-1 agonist is going to be much more effective in that overall. But you're going to find these are only injectable, much more expensive. You can develop antibodies to these drugs over a period of time, so you do want to be watchful for that. So certainly the anaphylaxis could be a risk, but you may actually find antibodies developed to actually neutralize the drug to prevent it from being all that effective. So potentially you could switch them over to a different agent and they may regain that efficacy there. In terms of safety effects, remember like pancreatitis, weight loss seen with the GLP-1 agonist, Stevens-Johnson's skin reactions are the big one for the DPP-4 inhibitors. So then we have the newest set of drugs here. So this is called the sodium glucose cotransporter 2 inhibitors. And again, these diabetic drugs just have like the best category names, right? But we call these the SGLT2 inhibitors here. And so, and also these have like the worst drug names possible. It sounds very, very awkward to say out loud. So I'm going to try it for you, but you don't have to. You can just say the brand name if you want. You have like canagliflozin. That sounds like a made-up drug on a TV show if I had to guess. There's dapagliflozin, there's empagliflozin, and then we'll actually find some combo drugs as well where you may end up using two of those together potentially, or maybe mix up with like metformin or something like that. But basically what these are going to do, this is kind of a novel method here. They actually inhibit the transporter in the actual proximal renal tubules to prevent reabsorption of glucose. Now, typical diabetic patients, if you did a UA on them while they're hyperglycemic, what would you expect to see? You expect to see glucose in there, right? This actually would cause much more glucose to be spilled out into the urine. So you're going to find that you're going to be preventing the reuptake in the renal tubules such that you pee it all out, thereby decreasing your levels of blood sugar, right? Because you just don't reabsorb it. This can lead to certainly lower blood glucose because again, it's not there, it's been eliminated, and may actually help to lose a little bit of weight because again, all those carbohydrates are being eliminated instead of getting shuttled into the cells or into the fat, right? However, there are some unique side effects associated with this. So if you leave a bunch of sugar lying around in the kidneys and in the urinary tract, what do you think could happen? Yeah, who likes sugar? Well, anything living does. So that includes things like fungus, and that includes bacteria and things like that. So urinary tract infections are actually quite common for these patients here. So 7 to 11%, so 1 in 10 patients roughly are going to get some UTI from this, right? So something to definitely warn patients about. You may also see issues of hypotension that can develop. That should be pretty mild, but could be synergistic if they're on other antihypertensive drugs there. You may end up seeing risk for kidney injuries. You do want to be cautious with that. Kind of a unique risk with canagliflozin specifically is this bone resorption or bone fracture risk, and it may have some effects on calcium being reabsorbed as well, so not great for patients like osteoporosis. That'd be one thing I'd want to be watchful for. And potentially it could actually cause patients to have this diabetic ketoacidosis, but interestingly it'd be a euglycemic acidosis, where again they may not be able to shuttle the glucose into the cells, but you're also peeing out a lot of that, so they would not be hyperglycemic because they're eliminating through the urine, but even though they're still having to rely on fatty acid oxidation for energy. So kind of a rare thing, but kind of an interesting point you don't really see with any of these other agents here. So question being, all right, so how do you manage these patients with type 2 diabetes? Because obviously if they're type 1 diabetic patient, what do you start with? everyone gets insulin, right? So it's pretty straightforward with that. In these cases here, most likely you're going to start off with metformin. It's the easiest, it's the cheapest, it's going to be pretty effective for a lot of patients here. I like this slide because it does give you a lot of information about the different classes, and when you're combining them, what are the risks you're actually looking for. So for instance, hypoglycemia risk, in this case here, is going to be, and again, this the slide's a little off kilter a little bit. So again, the efficacy in dropping your A1C is pretty high. So that's great, right? Metformin is very effective with that. The hypoglycemia risk for metformin is fairly low. Why is it low risk? Yeah, it doesn't cause any extra release of insulin. It just makes the stuff you're already sending out that much more effective, right? In terms of weight, you're going to find it's going to be pretty weight neutral, or may cause a little bit of weight loss. So we like metformin from that standpoint. And then ideas of side effects you want to be watchful for. So again, a lot of GI side effects, a lot of abdominal cramping and things like that, nausea, vomiting. The lactic acidosis being the really worrisome one though. And then the cost, fairly low, right? So it's nice because you can kind of compare and contrast the two together and see, okay, well, how do these different agents really stack up? So most patients will have metformin, as long as they don't have a contraindication like, say for instance, renal dysfunction, they'll be on metformin, and then you'll add on other things to that for the most part. So metformin is always the backbone to that regimen there. And so looking at, say for instance, our sulfonylureas, like what are the risks for causing hypoglycemia? Probably pretty high because they're causing a lot of extra insulin release there. Obviously, the big side effect to worry about is hypoglycemia, right? And again, you can kind of go and compare and contrast these all together, and may ask a question. A patient was on this, not being very effective, their A1C is still elevated, what would you may add on in this case here, right? Always, what is always the most effective thing you could add on to get their blood sugar under control? You can always add on insulin, right? Because patients could always move over to insulin to be very effective. However, what's the downside to using insulin? Hypoglycemia is a big risk, right? What else? Weight gain is going to be a big risk there. But certainly now they're going to be injecting themselves. And typically once they get on insulin, it's hard for them to come back off of it unless maybe they get their weight under control, get their diet under control, etc. So that's always an option, right? But it may not be the best from a patient compliance standpoint, may not be nice from a quality of life standpoint. So you can consider adding on these other ones. And again, things like costs are going to be a big factor here as well. So it'd be nice if you could put all your patients on a GLP-1 agonist. Very effective what they do, just a one-time weekly injection, pretty good, get their weight down. However, very expensive, right? So you got to kind of compare and contrast and see what's going to be best for your patient based off what they can actually afford in some cases there, right? And in some cases, you may need just basal insulin plus mealtime insulin. Not ideal. Typically, if you're starting off a type 2 diabetic patient, you just start them on a long-acting agent first. They don't necessarily need mealtime insulin there. They just need something to kind of boost up their basal levels to deal with that fasting blood glucose or kind of basal hyperglycemia they're dealing with. If I needed to put them on a long-acting insulin first, which agent might I choose? I choose insulin Lispro?
No.
I would not.
Clargy.
When would I use insulin Lispro? Short acting's around meal times, right? Okay, what would be a good long acting one? They use insulin, regular insulin? No, it's mealtime insulin too. How about insulin Detamir?
Yes.
That's a good one. How about insulin NPH? You could do it, and that's what we used to use, or maybe if they can't afford some of the more longer acting ones, you can consider that. But most often you'll end up starting them out on a long acting like Lantus, Levemir, or the Tresiba, that insulin Degludec. So any of those. You should be able to identify those for testing purposes, because I can ask a question like that and say which one of these insulins will be most appropriate for this setting, and you should be able to figure that out, right? That's a lot of energy today. I'm really feeling it in the room. It's palpable, the energy I'm feeling. Any questions on diabetes? Okay, I got a little bit more time, so we'll continue on before we have kind of a hodgepodge of other sort of endocrinologic issues here we'll look at. Definitely should be able to finish up today, and then the next session will be our review, I believe, right? And then the test. Your test is when? Oh my goodness, so close. So close, but it's okay. We'll be finished with the material today. It's only Tuesday, so I'll have nice long amount of time to review. We have all weekend to review for my test. Isn't that nice of us? So we used to not do that. I used to not put my tests on other days of the week. That was not great. Put them on Fridays. Can you imagine that? I had a Monday, Wednesday, Friday Pharm test. Oof. The student suicide rate is pretty high that year, so we just I'm just kidding. No. We've 0%. As long as I've been here, at least, that's been great. Just kidding. That's why we teach you about the behavioral health meds, right? So you know, okay, I'm feeling really anxious. I'm going to take myself a beta blocker for this test. But anyway, so Let's talk about hyperprolactinemia. We've talked about several. Are there any drugs that could cause hyperprolactinemia? Spironolactone. I have to double check if it specifically causes more prolactin. It does cause some aldosterone effects. Remember, it's a kind of a partial androgen agonist, right? We talked about that in terms of effects for male patients and female patients, kind of some estrogenizing, I don't know if that's a word or not, but some estrogen-like effects there. Remember, when you lose dopamine activity, you get more prolactin activity, right? So what set of drugs could do that? Antipsychotic drugs, specifically more likely your type 1 or your first generation antipsychotics. So something like a haloperidol or something like that could certainly cause hyperprolactinemia in your patients, right? So again, it can cause things like your menstrual irregularities, can cause gynecomastia in men, all of that. Because again, what does prolactin normally do for us? Helps out with breastfeeding, right? Helps out with actually nurturing and feeding an infant. So also, what's another big issue with hyperprolactinemia for female patients? They can't get pregnant. Why not? Why are they not ovulating? Because their body is thinking, the hormones are saying, well, you need to feed this baby that may or may not be existent, right? So your body's thinking, well, we don't need to ovulate right now. We have all this prolactin, or we must need to breastfeed something. And so it's not the case there. And that's a common reason why you'll see a lot of patients will have fertility issues. You may actually see them on something for hyperprolactinemia. We'll look at some agents for that. But remember that seesaw balance between dopamine and prolactin, how if you lose dopamine effects, you're going to have more prolactin and vice versa. So we'll look at some cases of that. Here, for instance, you can have a dopamine agonist most frequently being used here. And so you may find, for instance, like a patient who is having issues of getting pregnant, they may give them bromocriptine due to their hyperprolactinemia, for instance. And so this is a common one to give bromocriptine here. Again, it's an ergot alkaloid. If you recall back when we were talking about our agents for headache, remember we talked about like DHE, remember we talked about our bromocriptine being used. What could I use bromocriptine for? What kind of like major reaction to an antipsychotic drug? So dystonia potentially, yeah. What else? What's the kind of the more like really severe form of that? Not tardive dyskinesia. Yeah, neuroliptic malignant syndrome, that's the big one you could potentially use it for. So remember all the different cases here you could be potentially using. So again, frequently see it used for ovulation induction for those patients there. Are ergots good for pregnant patients though? Not great, right? Because remember they can be teratogenic, so we would want to be cautious with that. Just the really big things to watch for is going to be blood pressure, especially you get that orthostasis and get dizziness associated with that, and a lot of nausea and vomiting associated with these drugs as well. So you will see that pretty frequently. Cabergoline is going to be another one that also has high affinity for the dopamine receptor. They could also have similar effects. Again, just watch out for their blood pressure. It's probably the most common thing to let them know. Not a whole lot for that one, unfortunately. So you just remember high prolactin levels, give them a dopamine agonist, and they'll have to drop that back down. Okay, so next we'll talk about androgens briefly. What are we going to use our androgens for? This is like a really brief like section for the guys, and then like the females get like a whole section later on, so you guys get preferred treatment, get your whole unit, essentially. What can we use therapeutically? What can we use our androgens for? Yes, if they have low testosterone levels, we can replace that potentially, right? What else? We'll look at some cases, we'll look at some uses for it in just a minute. Remember that a lot of these steroids all sort of share the same common structure, the common progenitors here. They're all coming from cholesterol in some way from basically the cell membranes themselves, right? So you're getting those phospholipids down, converting them over and freeing the cholesterol. And there's a lot of interconversion here between different agents. So for instance, you can find cortisol can be generated from here. You can find things like aldosterone, which we talked about extensively last semester. And then we'll look at testosterone being formed here. And then also progesterone and estradiol. So again, these are going to have this interplay here that we're going to be noting. And we'll look at some different things and such as how affecting one side of the system may affect the other side, from androgen to estrogenic activity and vice versa. So we'll look at some different ways we can kind of monkey around with the system a little bit. We've actually talked about this a little bit already. If you recall back with our talk on cancer, is there anything that inhibited the conversion from testosterone to estradiol? Yeah, I remember our aromatase inhibitors. Remember what the side effects were for female patients taking that? Hot flashes. Why are they getting hot flashes? basically you're inducing menopause in those patients, right? We also saw andronizing effects as, you can see things like hair growth, you can see things like their voice deepening a little bit as a result of all the extra testosterone. So again, kind of think about how these things are going to be affecting one another. But testosterone itself is going to be one of the most important androgens that are made in the testes themselves. We make about 8 milligrams that are produced daily. And you'll find, though, that testosterone itself is not going to be the most active form of testosterone. It actually gets converted over by this enzyme called 5-alpha reductase. It's going to convert it over to DHT, or dihydrotestosterone. This one has much more androgenic activity. This one's also really important when we're talking about things like BPH, right? What does that stand for? Benign prostatic hyperplasias. We'll talk more about that specifically in the urology section later on. We'll get to that eventually, but DHT is going to be, again, kind of the major mover and shaker here in terms of androgen activity. Testosterone still has some, but not as much as DHT. You'll then find also testosterone itself gets converted over into estradiol by aromatase. You can see how we do still have a little bit of estrogen effects. I tell you that story about the guy who called up the poison center and his son got into the birth control. It's like, I mean, his child was probably not producing a lot of estrogen at that point, but again, anybody is going to produce some amount of it, right? You just don't magically turn into a girl like that. It'd be very unsafe drugs if that was the case there. It's all of a sudden just people interconverting willy-nilly from an accidental ingestion. Is crazy, but it doesn't work that way. However, people get pretty freaked out if they don't know science very well. Other big important things to know with testosterone, it also gets metabolized in the liver, and so this is going to be an important factor in terms of how we actually administer these drugs to patients. Can we give hormones orally? Yeah, we have oral contraceptives, right? I mean, that's the best way to, or easiest way, most common way to get estrogen and progesterone into a patient, right? Common way. So yeah, those are hormones. We can do the same thing with testosterone. However, you will find, because these all get metabolized in the liver, that oral administration of testosterone is going to be pretty hard on the liver. So this is not a common way we're going to do that. So as an alternative, we're going to be looking at other routes, things like transdermal routes. We'll look at injection, intramuscular injections, things like that. They're going to be the more common ways to get testosterone into your patients. And again, they work like just any other hormone. Once they get down into the actual cell itself, it's going to go down to the nucleus and actually change transcription factors. So again, it does take some time for these to kick in, but once they start working, they can have pretty powerful anabolic effects on the body. Remember, there's also going to be this negative feedback loop on the HPA axis, right? So for instance, here you're going to find that in the hypothalamus, you're going to be releasing GnRH. And again, we'll get much more into detail on this in terms of how it affects estrogen and progesterone in female patients later on. But here, just focusing on male patients, GnRH will be released, and that then stimulates pituitary to release LH and FSH. And that stands for what? LH is luteinizing hormone, FSH is follicle stimulating hormone. And actually, everything here is the same between male and female patients. There's no differences at this point. Once it gets down to the testes, though, that's where testosterone is going to be stimulated in its own production. But remember that everything feeds back and you can inhibit this system here, right? So for instance, with the testes normally producing a lot of the testosterone, if they're normally active, those should be a normal size and characteristic, right? What would happen if I were to start giving exogenous testosterone to these patients? It's going to shut down release of GnRH, it'll shut down release of LH and FSH, and then it'll shut down production in the testes. So just like if we give corticosteroids exogenously, it shuts down the adrenal glands, we can do the same thing to the testes. So what's a common side effect of patients who are on androgen therapy? Testicular atrophy, right? So exactly. So again, this all kind of makes sense if you understand that basic negative feedback loop in the HPA axis there. There's also inhibin that gets produced. So it also can have a negative feedback here, but I'm not going to focus on this too much because it doesn't really come into our interact with our drugs very, very often. Also, if you're looking here, imagine if you're shutting down testosterone production in the testes themselves, also what else gets shut down? Sperm production as well. So it can be difficult. Male patients can be infertile for the period while they're getting exogenous testosterone due to this as well. So that's another common issue with some of those patients. So there's a lot of different forms that are out there. I'm not going to grill on each and every different one out there, but just to give you some examples here, we have things like androgel, which is going to be a transdermal gel you can actually apply and allow it to be absorbed through the skin. So that's one way we can administer these drugs here, but other ways include things like depo-testosterone. Whenever you see depo, what do you think of? A long-acting formulation. It gets injected into the muscle, right? So it usually comes as an oil base, and that takes time for it to be absorbed as it kind of slowly gets released into the bloodstream, right? Typically, oils are not great to inject into the blood directly. Why do you think that is? Does the oil and water mix very well? No, they don't. They can actually cause an emboli in some cases. We actually have a drug that old school drug we used to use for certain types of poisoning. So for instance, like lead poisoning, we used to use this. It's a drug called British anti-lewisite. It actually comes in peanut oil. It has to be given intramuscularly. If you give it IV, it actually can cause really significant pulmonary embolism. But off of that tangent, back to the point at hand here. Any of the agents we're giving that are testosterone specifically, again, they will then get converted by a 5-alpha reductase and turn into DHT, right? And again, that's going to be the more active form for those patients there. There are other synthetic forms, and there are many, many that are out there. But there are ways we can actually either change, like say, the ester structure, or we can add on like maybe an alkyl group here or there, and you can get things like methyltestosterone, fluoxymestrone, oxandrolone. There's many more that are out there. These are typically going to be your oral agents. Testosterone itself is not going to typically be given orally. Typically, it's either transdermally or given via injection. Here, the oral agent, these are going to be the ones you see a lot of hepatotoxicity associated with. So that's one thing you would want to note. And why we don't really go with them very often, because hepatotoxicity is so common. So what happens when you're actually getting these androgens? What effects might you end up seeing here? So from the testosterone itself, you're going to find that will help to develop things like, skeletal muscle. So these are anabolic hormones. When you typically think of people who take testosterone, what do you think of? Bodybuilders, right? Like Arnold Schwarzenegger and Sylvester Stallone back in the day. All those guys, getting big, huge muscles could have been supplying exogenous testosterone, right? They said they didn't, so I believe them, but who knows? Anyway, another really important thing, though, that actually stimulates erythropoiesis, right? Why might that be beneficial? If you have patients who are anemic and maybe due to chronic illness, right? So say, for instance, you have patients who have like chronic wasting syndrome, maybe they have late-stage AIDS, maybe they have chronic cancer treatment. They could actually end up using exogenous testosterone to kind of help, one, put on some weight back on those patients there, but also help stimulate erythropoiesis to help get their hemoglobin back up. Could be one thing there. DHT, unfortunately, though, has some significant effects on things like hair follicles. So again, that's where you get like the male pattern baldness. A lot of that is coming from there as well. And remember, though, that all of this is then will get converted over into, to some small amount at least, to estrogen. So a little bit, depending on the aromatase activity, can do things like have effects on the bones. You can also see effects on things like libido as well, can be affected by that. So what are some therapeutic uses that we would end up using our androgens for? So typically things like male infertility. So again, we said that actually giving super therapeutic concentrations can actually cause infertility. Well, for male patients, maybe they're not producing enough on their own, we can help supply that, and then that's where we can end up giving help with their ability to produce sperm and actually be fertile again. And this says MT, that just stands for like methyltestosterone, so that's going to be those oral forms we talked about in terms of which ones we may commonly see being used there. What if patients had their testicles removed altogether, right? Well, we can actually supply that testosterone there. So if they had removed due to cancer or something like that, this is where we can just go ahead and replace what they are missing, because again, they'll be producing a ton of LH and FSH, but it really won't, there's nothing for it to work on essentially. Osteoporosis, because androgens are going to have positive effects on the bone, but also what do they get turned into? Estrogen, and they definitely have positive effects on the bones. That's great. Sometimes you'll see in hormone replacement therapy combined with some estrogen. This is not super common. Occasionally we may use it for inoperable breast cancer, because that may actually help in terms of decreasing some of the estrogen effects overall. Again, not super common, but occasionally you'll see that. And then this is a common one as well. We're going to see it helping with like chronic illness that causes a lot of weight loss, a lot of muscle wasting, and things like that. This can be beneficial. So I mentioned like cancer treatment, AIDS, and things like that. This is a thing you may see occasionally. And then we will have some anti-androgens, and it's going to also be very beneficial. So for instance, what type of cancer is commonly associated with high testosterone levels, high DHT levels? Well, like prostate cancer, right, for instance, because we'll find when we get to the urology section that the prostate is directly stimulated by DHT to grow, and if you cause an unchecked growth, you can actually cause cancer to develop eventually. And so we'll end up seeing that you can potentially use an anti-androgen to block that effect, right? You can also maybe use it as an anti-androgen for like hirsutism in females that may be producing excess amounts of testosterone potentially. So as I mentioned with the formulations that we have here, typically for the oral formulations, they are readily metabolized in the liver, because after absorption, that's the first place they're going to go to. And so just testosterone by itself is not great, because it's going to has too big of a first pass effect, such that it's not going to have very much bioavailability there. That's why we end up giving those alkylated forms, things like methyltestosterone and whatnot, because it's going to be able to be more sturdy. It's going to be able to get through the liver and still have some bioavailability there. The injections, though, typically you'll see as like these testosterone esters and oils, and again, that's going to provide a nice long-acting formulation. Those are typically depot forms you'll see there. And as I mentioned, transdermal formulations can be absorbed through the skin fairly easily. You might actually apply these to the testes directly, and then again, that thin skin can have some pretty good absorption. In terms of anti-androgens, we have a couple different things here. So for instance, you're going to have actual androgen receptor antagonists themselves, so specifically blocking testosterone and DHT from interacting with the receptors here. That includes things like flutamide and bicalutamide. These may be useful for things like prostate cancer to help decrease that kind of that pro-growth effect that it will have on the prostate. We talked about mixed agonists, so this is where spironolactone comes into play. So remember, spironolactone frequently causes what in male patients? Gynecomastia, because overall it's kind of reducing the overall level of testosterone activity, so you'll find those estronizing effects will be a little bit stronger for those patients there. And this is probably going to be a more common thing you're going to see for patients with BPH and potentially prostate cancer, but this is where 5-alpha reductase inhibitors come into play. And this is instead of blocking, say, testosterone at the receptor itself, it actually just blocks the conversion from testosterone to DHT, such that you have a less active form that's going to be more predominant. And so we'll see that used a lot for BPH. We'll talk more about that in the urology section coming up a little bit later on. So what are some side effects we expect to see with our androgens? We already talked about a few of them. So for instance, they did have a history of BPH. This is certainly going to be worsened by exogenous supplementation. Potentially can worsen prostate cancer, something you definitely want to watch for. I mentioned the testicular atrophy, because again, you're going to be shutting down that negative feedback loop, such that you're not going to have LH and FSH stimulating activity in the testes. Now, why gynecomastia? Why would you see that? Remember, testosterone getting converted to the estrogen via aromatase, right? So you may actually end up seeing patients who would be on a testosterone supplementation plus an aromatase inhibitor, and that can help to limit some of those effects there. So that's something you'll see. You'll find that you can get increased levels of erythrocytosis or increased levels of hemoglobin. You'll typically find that if they're already at normal levels, you shouldn't see them kind of go really super therapeutic with it. We'll find that more when we talk about EPO specifically being given later on in the renal section. But certainly we'll see things like due to sort of the ancillary effects of testosterone, because remember, it kind of looks very similar to things like cortisol. You'll see some mineralocorticoid effects. You will see some fluid retention there. Could be a problem if you have patients like CHF, for instance. So we want to be cautious with that. And then in terms of hepatic effects, specifically more for the oral agents there, this is where you can see things like cholestasis. You end up seeing hepatitis that can develop with this. So just be watchful for that. It can happen with other formulations, but more often it's going to be with the oral formulations. And then you actually end up seeing masculinization in women. So why would women be taking testosterone? There are female bodybuilders out there too, right? So there may be some other reasons, but that's kind of the thing I think about most commonly. Again, they can get that hirsutism. They'll certainly get the anabolic effects on the skeletal muscle, but they can even have things like either voice deepening and things like that you would see from the masculinizing effects. So we'll talk more about our treatments for BPH later on when we get to the urology section, as I mentioned there. But again, frequently we either use like our DHT inhibitors, or basically drugs that block 5-alpha reductase to prevent conversion from testosterone to DHT. This is where we have things like finasteride and dutasteride. We'll talk about a little bit later on. And then we can actually end up using things like GnRH analogs. So again, this can be used to basically inhibit that negative feedback loop as well, and that actually helps to decrease testosterone production in the testes by shutting down the HPA axis there. So these include things like leuprolide and gozerelin. There's some other uses for that. We'll talk more about that later on when we get to the OB-GYN section later. So, and again, as you might imagine, giving something like GnRH, you'll actually end up finding that by using an analog here, by using low levels, you can actually stimulate this activity here. You can actually stimulate testosterone production. Other cases, you can actually give too much of the drug and give higher doses. That actually will shut down this whole system here. So there's kind of different ways that the agonists will work depending on the dosing you're actually administering for those patients. So any questions for that? The androgen specifically. How many slides do I have left? About 20. You guys want to take a break or no break? Break? Boy, you guys need like a nap, I think. But yeah, let's do a 10-minute break. We'll come back and then finish up. Getting into androgens, what do they cause? Erythropoiesis or erythrocytosis? Well, erythropoiesis can lead to erythrocytosis, so yes, they can do both. Okay, how do I assess the adequacy of circulating blood volume? A very important pharmacologic question here. how do you assess the sufficiency, the adequacy of circulating blood volume? Which are some things I could look at? Urine output could be one, right? Very good. What else? What's a good urine output for an adult patient? So like 0.5 to 1 mLs per kilo per hour is typically considered sufficient. How about for like a pediatric patient? Usually greater than 1 is good. So greater than 1 ml per kilo per hour is typically considered pretty sufficient for a pediatric patient. You'll find they can go well above that. So I've seen kids that will be peeing out like 6 to 8 mLs per kilo per hour. So it can be pretty significant diuresis there. What are some other ways I could look at blood volume, determining if it's adequate or not? Blood pressure is a really good way to tell too. If they're hypotensive, well, it stands to reason that they have low pressure. It could be related to volume, and that's oftentimes the first thing we'll do is give them what? We'll give them a fluid bolus typically, right? So if you have a patient who's hypotensive, they're not perfusing well, or some other ways you can tell they're not perfusing very well. Color, temperature, maybe if they're not circulating very well, extremities are cold. There's also things you could do more internally, more invasively. There's like things like central venous pressure you could also look at to see if that is adequate. If that's low, that typically shows us that the tank, so to speak, is empty, and so we need to tank it back up with more fluids. So again, what kind of fluids do we like to use for that purpose? Normal saline works very well, right? So that's why typically patients will get like a normal saline bolus. You could use lactated ringers, anything, any IV crystals would be totally fine there. We'll talk more about fluids when we get into the nephro section coming up a little bit later on, but that's kind of my thing. So, usually blood pressure, urine output are pretty good signs to look there in terms of the circulating blood volume. I don't know, did that come up like during surgery or something, or just a random question? Okay, so random surgery question here. Why do we stop patients off their anticoagulants only to start them again on Lovenox right before surgery, then again after? Also, why would we give vitamin K prior to surgery if our patient on low molecular weight heparin has an INR of 1.5? That's a good question. Is there any other context of the question you guys could share? That was just it? That was the whole thing. Okay. So So think back to when the mechanisms for how our drugs are working. Also think back to things like durations of action in terms of reversibility as well, right? So these are all considerations you want to make, because obviously the biggest risk for using an anticoagulant is bleeding, and a big risk during surgery is bleeding, right? So we want to make sure we can control that, right? So for instance, using something with like a really short half-life, it can be beneficial, because if we maybe they have over anticoagulated the patient, well, what can you do? So I give them a heparin drip, and on a heparin drip, and I come back and what do I use to usually monitor heparin? APTT, right? And it comes back and it's too high, or maybe the patient has evidence of bleeding. Well, what can I do to that heparin drip? Stop it, right? Or potentially I could reverse it too. I can give them protamine and actually neutralize the drug itself. So there's a benefit to having short-acting drugs, because if I cut it off, it's going to be relatively short-lived, and they should go back to normal functioning. Remember, how does heparin work? Yeah, it works directly to inhibit activating clotting factors by working with antithrombin 3, versus something like warfarin works by doing what? Inhibiting the actual process of forming those clots forming the clotting factors in the first place, right? So again, which one takes longer to kick in? Warfarin, right? Because it doesn't do anything to the already active clotting factors, but it actually affects the production thereof. It takes a few days for it to really kick in. So the question is, what type of anticoagulation is your patient on prior to surgery? Which may, if they're on warfarin, for instance, you may want to give them that vitamin K to get their INR back to normal, but then give them low molecular weight heparin or heparin itself, unfractionated heparin, in order to bridge them during that period of time. So say, for instance, they have AFib, but they need to go to surgery, you're still worried about those clots that can form in the atria, so you can bridge them and put them on a heparin that has a shorter half-life than, say, something like warfarin, or a shorter duration of action, something that's more easily reversible, and it can be on during that period of time, right? And then you can say cut it off for the surgery where they're at biggest risk for bleeding, and they come out of surgery, put them back on it when they're at a low enough risk to where you want to still anticoagulate them because of whatever reason they need to be anticoagulated, right? So for instance, if they go like a total knee replacement or something like that, we know that they're going to be laid up in bed for a period of time, and we worry about venous stasis leading to clots and DVTs. So obviously ambulation is a big important thing to do there, but we also give them low molecular weight heparins to prevent them from bleeding, or from clotting up, right? That's what answers the question. In terms of the INR, so again, if the INR is elevated, does Lovenox have any effect on INR? It shouldn't, right? So if the INR is elevated, it's usually something to do with the liver itself or a clotting factor issue. So it's okay to give them vitamin K to get the INR back down to normal, which would be what? 1. But the Lovenox is not going to be effective in those cases. There, Lovenox is still going to be just as effective as if the INR was 5 or if it's 1, right? That answer the question, I hope, sufficiently to your satisfaction. Okay, let us continue on. Last couple slides here for your second section. You'll be halfway done with your Pharm 2 class after this. Pretty exciting. Okay, let's talk about adrenocortical insufficiency. So this is a good segue from talking about the androgens into the corticosteroids. We've talked about corticosteroids quite a lot. We know that we use them for all kinds of different indications. And in fact, if a patient shows up and they feel bad, give them a pack of steroids, right? Everyone feels better after that, right? Not really, right? But a lot of things do certainly can be treated with corticosteroids. And we already know what a lot of those effects are going to be. So for instance, in terms of their activity at the glucocorticoid receptor, what would you expect to see? Increased glucose for sure. This is where you also get a lot of your anti-inflammatory effects are going to be coming about from this, right? So if they're coming in with an asthma exacerbation, we're seeing a ton of that. I probably send out more albuterol and Decadron than I know what to do with working in the hospital during the wintertime months. But also remember the mineralocorticoid effects as well. Those are also very important in terms of helping out with blood volume. So that kind of is a good segue from the question talking about adequacy of blood volume. This is where mineralocorticoid effects can also be playing a role. So if I had someone who had adrenal insufficiency and maybe they didn't have enough actual mineralocorticoid effect, and particularly aldosterone is the most common one or the most important one, what would happen to their blood pressure? It would be diminished because they can't hold on to that fluid in the vasculature, right? So that's why if you have patients who have hypoaldosteronism, they would have issues with their blood pressure, right? Versus hyperaldosteronism, you find that they actually would have more effects to hold on to that fluid, maybe see edema as a result of that, for instance. Because again, it's affecting that reabsorption of fluid, of water, in the distal portions of the convoluted tubule and into the collecting duct, right? So remember, those are the two main effects there. And again, depending on the steroid that you're giving, or the corticosteroid you're giving, you may see a balance between those different actions there. So you may have drugs that work more heavily on the glucocorticoid side and have very little mineralocorticoid effects, and vice versa. And then some will just be a blend of the two there. Ourselves, we produce cortisol, we produce hydrocortisone, essentially the same thing. And you can see that, again, we don't just secrete the same amount all throughout the day, but it depends on the time of day, depends on our stress levels, depends on all sorts of things, right? You guys probably have a much higher cortisol level coursing through your bloodstreams right now, especially on Monday morning, than I do. I would, I'll actually be at the beach celebrating my wife's 40th birthday. I know she's very special. She already turned 40, but we're celebrating her birthday this weekend. So I'll be much more relaxed, much less cortisol than you guys will. So just to give you a comparison. Anyway, I'm not trying to rub it in your faces, but humble brag now. Anyway, so looking, say, for instance, at insufficiency of corticosteroid, right? So for instance, like Addison's disease, which is pretty characteristic of this, you could expect them to see things like weakness and fatigue. Again, you can see things like electrolyte disturbances as a result of this as well, due to the diminished mineralocorticoid effects. And again, they have a hard time maintaining glucose levels as well because they don't have the glucocorticoid effects to go along with that. So blood pressure issues, glucose issues. And you can find that even in minor cases of, say, stress or trauma, you can find that whereas we would have a very easy time releasing more cortisol into the bloodstream to deal with that stress, you find these patients can actually lead to very easily go into circulatory shock. I had a patient who was a frequent flyer to the ER who had a pituitary tumor that was removed, and so they had issues of secreting ACTH, right? They actually would stimulate the adrenal glands to release things like cortisol. And so they would frequently come in hypotensive, hypoglycemic, because they could not release enough of their corticosteroids on their own. Now, chronically, they would take their own exogenous forms of the steroids, but sometimes, they get sick, they get a cold or something, and it could lead to some pretty severe consequences, usually them in the ICU. So those cases that we can administer, say 20 to 30 milligrams exogenously orally, and then supplement that if they need extra. So if they feel like they're stressed out, or they know, they'll kind of learn their own rhythms themselves, they'll be able to give themselves more if they need to. Another interesting one that's more unique here, which we've not talked about before, is a drug called fludrocortisone. And this is actually going to be just a pure mineralocorticoid receptor agonist. And so the benefit here is this going to be much better at helping to retain more salt and more fluid, and that is going to help with their blood pressure. So you may see a patient who's maybe taking hydrocortisone, say 10 milligrams 3 times a day, plus fludrocortisone as well to help out with their blood pressure. Just depends on their disease state. Typically, we would avoid more long-acting non-salt retaining because it's going to have some interferences and have a harder time maintaining their blood pressure there. But fludrocortisone is probably the newest one. Certainly, hydrocortisone is probably a very common one we'd administer, has nice balance effects, but you may see them on prednisone, you may see them on dexamethasone, just depends on the situation. Any questions about that? Okay, so then getting into thyroid pharmacology is probably the last thing I think we're talking about today. So certainly we can have issues of either hyper or hypo secretion of thyroid hormone from our thyroid gland. We have a couple of different forms of thyroid hormone. What are the main forms? T3 and T4, right? And which one's more active? I heard some dissent amongst the group. T3 is a more active form. Okay, we're going to find T4 is kind of a nice, like, kind of sitting on the sideline, waiting to be converted over to T3, and then it's active, right? More active. You can find that the secretion, either too much or too little, can happen kind of from any level. So it could come from, say, like the thalamus, hypothalamus, could come from the pituitary gland, could come from the actual thyroid gland itself. Any sort of disruption there can lead to hyper or hypo secretion. What's an important ion that we need in order to produce thyroid hormone? Iodine, right? So, and again, you'll find that this is typically an issue as well with, like, say, developing countries, where they may not have a lot of iodine supplemented in their foods, and they can develop goiters and things like that. So we'll look at some ways we can manage this. In terms of hyposecretion, they have hypothyroidism. What's going to be the best way to help treat them? We give them thyroid hormone, right? We'll look at some different formulations thereof. What would I do if they had hypersecretion? The most drastic thing I could do is cut the whole thing out, right? Let's say I didn't want to do that. What else could I do? So we're going to look at some medications that will block the production of thyroid hormone. We'll actually look at some things that may be helping block the conversion from T4 to T3. So there's some different ways we can manage that, and we'll get into those in just a little bit. So, and again, this HPA axis is very similar to what we saw before, say, for instance, with looking at testosterone production here. Again, the only difference is what the kind of in target organ is going to be, which is going to be the thyroid gland at this point here, right? So remember, TSH is going to be stimulating release of thyroid hormone production and release of T3 and T4. Again, these will have a negative feedback loop on both the hypothalamus and the anterior pituitary gland. So if I have a patient with hypothyroidism, you'd expect T3 and T4 levels to be low, but TSH level to be high, right? So it's important to remember that distinction there. But if I was giving exogenous T3 and T4, the TSH level should go back down. Should be getting close to normal if you're kind of supplementing like you should be, right? So anyway, so how do we actually produce thyroid hormone? What's the process here? And I'll go over this textually in a slide or two. But essentially what you're going to have is you're going to have iodide coming into the actual cells here within the thyroid gland, right? So you're gonna have the iodine come in. You'll end up having this conversion here. This peroxidase enzyme will interact with the iodine, and then it gets this organification process where basically it's gonna have a tyrosine added on, it's gonna get attached to this thyroglobulin, and then you're gonna get a couple intermediary products here called monoiodotyrosine and then diiodotyrosine. And then how you combine those together, you either get T3 or T4 essentially. From there, then you're gonna find you're gonna break off that thyroglobulin, right? Undergoes a proteolysis process, and then it just gets secreted out into the bloodstream as both T3 and T4, right? T3 being the more active form, T4 can be interconverted in the bloodstream over to T3, where it can then be more activated at that point, okay? We'll find there's ways we can interact with this to prevent this conversion, which may be useful for things like, what happens when you have like way too much thyroid hormone in the system? So you get things like tachycardia. What do you call that though? So there's thyroid storm, thyrotoxicosis as well could also be another term used there. I don't know where where they got storm specifically. Why not a thyroid hurricane, thyroid tornado? Just storm. That's what they came up with. But regardless, so what you're going to find is we get this iodide trapping that actually occurs here. Interesting thing to note. So what would happen? Let's say there's a nuclear blast that went off. Say we were not in the blast zone, but we were going to be exposed to some of the radiation. Potentially. What's one of the most dangerous molecules you might be exposed to? Well, it's radioactive iodine. So actually, if you were to be in that sort of setting there, what are the big things to worry about after nuclear blast actually happens is hypothyroidism, because you actually find when you uptake a lot of that radioactive iodine into the thyroid gland, guess what that radiation does? Destroys the thyroid gland itself, right? So actually hypothyroidism is a really big concern for patients who have been exposed to radioactive iodine. Guess how we can actually also get rid of the thyroid gland therapeutically? We can give them radioactive iodine as well. So look at some different uses for that a little bit later on, but a little tangent. But getting back into it, as I mentioned, there's the iodine trapping. It'll get transported into the thyroid gland itself. It'll then be oxidized to iodine. So it goes from iodide to iodine. Again, I usually say interchangeably, but that's what happens there. And you can find as well that not only will low levels of iodine in the system lead to hypothyroidism because you can't produce enough T3 and T4. Actually, having too high levels of iodine can also cause the opposite effect and decrease this process here. So basically, high levels of iodine can also lead to hypothyroidism as well. So it seems like kind of oxymoronic. They can do both, but that's the situation, right? Once it gets combined to that tyrosine, and that's when it's going to get converted over and then get combined together to either form T3 or T4. I have a picture of what that looks like in a second here. But again, you're going to find that if you get two molecules of diiodotyrosine together, that's two iodines, two molecules of that put together, what do you get? T3 or T4? T4, if I do a monoiodotyrosine and then a diiodotyrosine together, I get 3. Right, so I get T3 at that point. So pretty straightforward when you look at the picture here in just a moment. But again, T3 is more active form. Where's that slide? I was talk about that. It's somewhere on here, right? So if you were to look at this here, this thyroxine, would be the T4. You notice here there's 4 iodine molecules together. This would be if you had 2 diiodotyrosines coming together. If you had T3, this would be a monoiodotyrosine plus the diiodo put together. So that's kind of what that looks like, just in case you're ever curious. So anyway, so the hormone release itself, so once we have that bound thyroid hormone, it's going to be able to cross the apical membrane. It undergoes that proteolysis where it gets rid of that thyroglobulin. And again, this is another case where high levels of iodide could actually inhibit this. So another case where using high levels of iodide can actually cause hypothyroidism, or maybe be able to actually manage hyperthyroidism, right? So you have too much thyroid hormone in the system, you can actually give high doses of iodide to help prevent that. You can kind of use it either way. And then once it's released, T3 is going to be 3 to 4 times more potent. T4 is kind of considered a pro-hormone. It's kind of not all that active until it gets converted over. And so again, this is another case where high levels of iodide can actually be used to inhibit this process. So if you had thyrotoxicosis, it may seem, again, counterintuitive to give them iodine because you think, well, that would just produce more thyroid hormone, but actually can inhibit this conversion process here. So once it undergoes, T4 undergoes that deiodination process, you can actually form 2 varieties. There's T3, the normal one, which is active. It can actually also form this reverse T3, which is actually the inactive product there. So that's one thing to kind of note. Clinically, it doesn't really come up all that too often, but this is what reverse T3 would look like, and actually is inactive at that point. So this is the more active form here, the regular old T3 we're familiar with. So let's look at our therapeutic agents. So we have someone who's has hypothyroidism. We want to help supplement that and replace that. So what can I give them? Well, we said already you can give them replacement thyroid hormone. So can I give them T4 or T3? Which one would you want to give them? Why T4? We just said it's the non-active form. Well, in cases of the thyroid gland, is this like a really fast thing we need to fix typically? Nah, it's not usually a medical emergency. As long as it's not like thyrotoxicosis, it's usually not going to be a big emergency here. So things take a while to fix here, and so we're going to find that it's okay to move a little bit slow. And so the most common agent we're going to use here is actually supplementing them with T4. So when you see levothyroxine, that is just T4 that we produced ourselves. So you see Synthroid is probably the most common brand name you're going to run into. Most patients are probably going to end up getting put on this for hypothyroidism. And so the nice thing as well is it's going to have one consistent potency, which is one benefit of why we like to use T4, keep the levels relatively consistent, and then prolonged duration of action. So this can last for up to a week in cases of, for its actual duration. And in fact, what's interesting too is, so if I had a patient or someone call me up at the poison center and they say, oh, my kid got into all my Synthroid, say they took an entire bottle of Synthroid, am I concerned right at that moment? Actually, I'm not, because T4 is not really all that active, but what I'll actually do is set up a call for them a week later to see how the kid's doing. Because at that point, all that T4 gets converted over, and we can actually see, do they have an issue to where they would have signs and symptoms of hyperthyroidism, right? So it's kind of an interesting thing there, that it does take some time for it to actually become active. We will typically use this orally. Most commonly, there are parenteral forms that are available here. Actually, the only place I've ever really seen IV levothyroxine being used is in the case of TransLife patients. Anyone know what TransLife is? So it's actually for transplant patients who basically have been declared brain dead, that we're going to be harvesting their organs to give to other people, essentially. We call them, they have TransLife is typically the company that we have come in that helps manage that. And we'll actually give them IV levothyroxine to help kind of manage their hormone levels, because once the brain's basically shut down, it's not releasing a lot of things like TSH at that point to help regulate that. So that's something you may see occasionally. You'll see like in ICUs and whatnot for patients who are going to not be able to kind of come back from whatever injury caused their brain death. The drug interactions, though, you want to be cautious with levothyroxine or multiple via the oral route. So watch out for things like iron, calcium, other things like that will certainly bind it up and prevent absorption. So you always want to make sure they're separating that out as best they can, so that way the Synthroid doesn't interact with anything else. You may find that just due to having that extra thyroid hormone around, you may actually find this increase in metabolism overall, because it kind of helps the whole body metabolize things more quickly. That can actually have some effects on things like CYP enzymes. You may find that other drugs that induce CYP enzymes may also expedite the metabolism of Synthroid, making it less effective. So we would want to be cautious with that. In terms of other products we can potentially give, this includes things like liothyronine or T3. So certainly, which one will work faster? If I just give the active T3 product. Problem though with this one, you're going to find that while it does have a much faster onset of action, which would be good if you need it right away, typically you don't, you tend to find that you're going to need more frequent dosing for this one. Right? You may have to give it multiple times a day, and also the cost is going to be a lot higher. So this is why most people end up just kind of going with Synthroid. Most of the time you don't need that quick of a replacement. There's a couple other ones as well. So for instance, there's like Liatrix, which is a 4-to-1 ratio of T4 to T3. So it's kind of considered to be a little bit more natural in terms of what our normal resting state or resting ratio is, a T4 to T3. And again, this one is oral only, so you may see this occasionally. I don't really see too many patients on that. Synthroid is good for like 95% of patients out there. And again, where we're going to be using this most frequently is going to be for those with hypothyroidism, as you might imagine. So Hashimoto's, you can use it for myxedema, if they've had a thyroidectomy. All these are good cases where you want to replace thyroid hormone that they don't have themselves. Or if they've undergone a radioiodine ablation, that's where you actually give a patient radioactive iodine to ablate the actual gland itself, right? If they had cancer or something like that, right? What will this do to weight? Patient's weight. See, Synthroid would increase or decrease weight? Actually decrease it, right? So sometimes we'll see patients who will be using it for other therapeutic purposes like weight loss, but they typically don't recommend that. And why do you think that is? We can get things like hypertension, tachycardia, right? And it's not necessarily all that too easy on the body, so they don't usually recommend it for weight loss, but you'll find some patients are using it specifically for that. So again, how's the actual thyroid hormone working? Well, once it gets into the cell, it works like any other steroid. It's going to get down to the nucleus and start to change its transcription factors. And again, depending on the tissue, depending on the receptors actually binding to the nucleus, you can get varying effects that can occur there. So for instance, things like blood pressure effects or things like effects on overall metabolism in the body and whatnot. And that will lead to the downstream protein synthesis changes, right? So what could we do if we needed to, say, block the effects of thyroid hormone? We wanted to maybe decrease the amount that we're actually producing in patients with hyperthyroidism. We have a couple of them. So one, we have these thiourolines, or the thioamide family. These are going to include two different agents here, and this is including propylthiouracil, or PTU, how it's frequently called, and then methimazole. And so basically, these are going to be used, and I've probably seen methimazole used a little bit more commonly, typically due to its longer half-life and a little bit better potency than PTU does have. Overall, they're also going to be pretty well tolerated. I'll talk about mechanism in a second. Biggest thing to watch out for, though, is going to be with agranulocytosis. It's a rare complication, but can occur in some patients. So you would want to watch your CBCs. So how do they work? Basically, they're going to block the oxidation of the iodine ion there, such that you can't get that next step of organification and then produce the MIT and the DIT there, right? We talked about before. So by doing that, basically you're stopping production of T3 and T4. Now, does this do to anything of current symptoms of hyperthyroidism? No, you can kind of think about this like warfarin works in the liver for clotting factors. It doesn't do anything to active clotting factors. These drugs don't do anything to active T3 and T4, but they block the production thereof. Okay, so this is mainly where they're going to be used here. So for instance, with like Graves' disease, you could use this to help block the production thereof, because they actually have this autoantibody that is producing, that acts a lot like TSH. So giving this would help to block the actual production of T3 and T4. Or sometimes, well, should you give it to try to shrink down the gland by decreasing its activity, and that helps to get it a little bit smaller and easier to take out via surgery. Other things we can do includes radioactive iodine, as I mentioned there. So again, we can do this therapeutically to try to basically have the thyroid gland take this up, and then once it's actually in the gland itself, it releases these gamma and beta particles, and that basically causes cellular damage, causes apoptosis of those cells itself. So just like we would use this for any other type of cancer in terms of radiation, this is a very targeted way to do that because iodine basically just likes to hang out in the thyroid gland, as it turns out. We could also just use things like, actually, and again, what do you think is the biggest complication using radioactive iodine? As I mentioned, hypothyroidism in most patients. And that makes sense because you're ablating a lot of those cells, so not great. But if you're using it for cancer, that's totally fine. And then you can just put patients on Synthroid afterwards and help to replace that. Again, so what could I do? Say, for instance, you were exposed to that nuclear blast and you were worried about having all that radioactive iodine. What could I do instead to help prevent that? I could take regular iodine to try to help sort of saturate the thyroid gland to prevent the radioactive stuff from being uptaken, and then I could just eliminate it from the body. And so in fact, if you look at a lot of like bug out bags or like people who are like, crazy doomsday preppers, they always have iodine. And that's the reason why, because they don't want to get hypothyroidism when the big one goes off, right?
Brilliant.
Could happen. You never know. It's crazy times we live in these days, eh? Anyway. Other things we could do, we could actually give saturated iodine solutions to patients. And so here's one called Lugol solution, which is actually potassium iodide you're giving to patients. And this is, again, used to treat that hyperthyroidism. Remember, we saw that high levels of iodide could actually block several steps along the pathway of producing T3 and T4. So this can also be used occasionally. Sometimes used in conjunction with things like the thioamides like PTU or methimazole, sometimes used by itself, depending on the case there. And again, you can actually end up seeing, as in terms of complications, iodism that can actually occur, where you can get things like swollen salivary glands, you can get fever, mucous membrane ulcerations, and things like that as a result. So again, iodine itself seems like it's totally safe, but it can have some issues if you're kind of chronically ingesting too much of it. So in occasion, we can actually use our contrast dye. So again, a lot of the dyes you'll use for things like CT scans and whatnot actually contain iodine within them, and this could be an alternative you can actually use to help treat things like thyrotoxicosis. High levels of iodine can prevent conversion of T4 to T3, and that can be used to help kind of treat these immediate sort of symptoms that they're coming in, really hypertensive, tachycardic, hyperthermic. They can actually help to decrease some of that activity there. Kind of off-label use for that. So that's it for thyroid pharmacology. Pretty straightforward. Remember, it takes a couple of weeks though before you're really going to see any changes. So typically, you'll see have patients take their dose of Synthroid 4 to 6 weeks or so, and then have them come back in and check out their levels to see where they're at. Right. So it's a slow process, not something you're going to fix overnight in a lot of cases. Okay. Any other questions before we break for the day? A nice hour-long lunch. It's gonna be pretty sweet, right? I hope you guys have a great day. I'll see you next time for our review and then the test. I'm going to have all of your prescription assignments. You guys are working on that, right? I'll have all the feedback out by tonight.
Wow.
I know, it was my New Year's resolution. Wow. I said, I'm going to do better for these guys. I'm going to have it out by tonight. That's my goal to myself. Okay? So if I don't do it, you're going to have to haze me on the internet. Leave all the negative comments on my YouTube channel now. Okay. All right, I'll see you guys next time. No, don't do that.